Great. I think we should get started. I don't really actually like giving didactic, so feel free to ask questions and just have more conversational presentation. It's kind of ironic that I was asked to do this lecture because I'm known for maintenance treatment, and detoxification is not actually one of my areas, although the more I thought about it, now I realize why they asked me, because often I get pain patients refer to me for detoxification that are usually complicated. So I'm medical director of the Beth Israel Methadone Maintenance Treatment Program. I don't know if any of you are familiar with it, but we have 18 clinics throughout Manhattan and Brooklyn and serve over 8,000 patients a year. I'm trained as an internist, but I also completed a fellowship here in hospice and palliative care, and I have my pain boards, no conflicts. So today we're going to talk about detoxification strategies for commonly misused drugs and or medications requiring a medically supervised detox. So those that are potentially difficult to have and have difficult and dangerous withdrawal syndrome. So really I'm going to focus on opioids and benzodiazepines. They asked me to do inpatient or outpatient, so we'll just go over that briefly, and if we have any time at the end we can do some case studies. So the purpose of detoxification is obvious to relieve withdrawal symptoms, to prevent complications from withdrawal, and this here, to address the inpatient-outpatient question, to detox on an outpatient basis, which is probably what most of you are doing and what I do. The patients really need to have relatively low medical and psychological needs. They need to be motivated. They need to have a lot of support. They haven't failed detoxification. You usually give them a test as an outpatient, and they need a structured life and a living environment supportive of recovery. This is not what I usually deal with in the methadone maintenance treatment setting. Patients really don't have that support system, so they go for inpatient detoxification here at Stye Square. So just to quickly go over benzodiazepines, I'm really an opioid person. Just so you know, benzodiazepines are very rarely the primary drug of abuse. Usually in the methadone setting or when not in treatment, it's part of polydrug abuse, and they're often used to treat withdrawal symptoms, or what happens in methadone maintenance, the benzos are taken with the methadone to sort of boost it so you can get a high on the methadone. There's all sorts of things going on there. And patients who misuse these medications and need detoxification should be treated in a substance abuse setting, either inpatient or in the program. And obviously we have a really hard time doing that, but that's a whole other can of worms. But the inadvertent dependence on therapeutic doses, which you may be prescribing in your practices, the number who become addicted or abusing them when taken to treat anxiety is really very small. You can do a gradual taper of using the current benzo. You can switch to a long-acting benzo. Then there's phenobarb substitution. That's what used to be done in Stye Square. I don't recommend that. And you can use other medications to treat the withdrawal symptoms, or a combination approach. So the real problems with taking patients off benzodiazepines, there's a reason people use these drugs. They have terrible anxiety symptoms, panic attacks, they can't sleep. Often you'll get rebound anxiety or the discontinuation syndrome, which is potentially dangerous, with tremors and seizures, which can be fatal. Often, and I would think in pain management setting that you're in, if you have a patient supported with cognitive behavioral therapy, this can help them cope during the detoxification process. So the patient really needs to be motivated. They have to want to get off the benzodiazepines, which is often not the case. And the clinician needs to explain that it needs to be a gradual taper, because some will be so motivated they'll just stop and they don't realize that they can have seizures and perhaps die, and also the rebound anxiety. The rate of reduction varies from patient to patient. It depends on the original dose, how long they've been treated, but the general guidelines that are recommended to prevent seizures and do it safely is 1/4 of the daily dose is the maximum amount reduced each week. Therefore, the minimum time for taper is 4 weeks. Now, this is best case scenario. The reality is it usually is much slower, and you often have to stop and restart or go back up again, and you know, you don't want to destabilize a stable patient, because usually someone who is ready to come off is stable. So the goal here is not to destabilize them. So if they were using short-acting benzos such as Xanax or Ativan, which seems to be prescribed by primary care physicians a lot, I personally don't use it. These are drugs that are more likely to cause dependence because they act very quickly, they have peaks, and then it goes down and there's withdrawal symptoms. So I either only prescribe to start with, or if I'm going to do withdrawal, I'll use clonazepam, I suppose Valium, so it's sort of self-detox because of the long half-life. This is... Sorry?
How many times a day?
Well, how many times for detox, or for how are my patients actually taking it? I mean, usually I'll just prescribe and say, take it at night. The reality is patients who have anxiety syndromes and symptoms, often pain patients, or even I give it to my substance users who are on buprenorphine. I am comfortable with them taking 1 milligram 3 times a day max. And it's amazing they can, and many patients really need that. When it gets above that, especially when I'm prescribing it with of the risk of sleep apnea and all the other overdose, at that point I'll refer them to a psychiatrist. And also try to explain to the patients that really this is not the treatment for anxiety. You should be using an SSRI or some other long-term anxiety medication. But they often want to stay on their clonazepam. So if they're functioning, again, activities of daily living, quality of life's good, they don't seem to have escalating use, I'm comfortable prescribing that. But that's as high as I'll go with my population before calling in psychiatry. I don't know, what are you guys prescribing and seeing in your practice?
I have a couple patients and they're on that 1 milligram 3 times a day.
4 milligrams 3 times a day?
1.
1 milligram 3 times a day, yeah. So you're not really going above that either. I mean, I know the psychiatrists do, but at that point, you got a real anxiety problem. So yeah, so if you do 1/4, I have a patient now actually who came to me from with chronic pain, who was taking clonazepam 1 milligram 4 times a day, fell asleep at the wheel, had a car accident, and I'm like, the drug you have to come off is the clonazepam, and that's like the hardest one. No one wants to take her off that. So it's not the opioids. You need the opioids for the pain, but come off the clonazepam. But anyway, clonazepam has a more sustained and gradual anti-anxiety effect, and this facilitates a smoother discontinuation without the negative withdrawal sequelae. Reality is, you can also use propranolol, clonidine. Carbamazepine, I have never used that. I know the side effects are just do not seem worth it. When I was writing this up, I did, however, find a recent study using oxcarbazepine, has anyone heard of it, in Germany? So, which doesn't have the bone marrow suppression. And what they were trying to do was a rapid detox over, I think they did it over 11 days, using this to prevent seizures. This was in a hospital setting. I don't know if I'd recommend it. But you can. I use clonidine a lot. I don't use propranolol so much. And phenobarb, because most of my patients are on methadone, that increases the P450 cytochrome. So I don't like to use that either. If you have patients on opioids and methadone, but that's what they recommend all the time. You can use phenobarb afterwards to treat the recurrent rebound anxiety. Personally, if you're going to put them on phenobarb again, I like using clonazepam, so I do use it a lot. If discontinuation, distressing, dependence high, or rebound anxiety, this is the most common situation I've been in after several attempts. maybe you should continue the benzodiazepine treatment. I mean, the whole point here is patient stability. Do not destabilize a patient. So I think we need to accept that low-dose benzodiazepines for many patients, whether they have chronic pain or not, allow them to function with the fewest negative effects. So there are people who take benzos at night, same dose every night for their whole life, and don't develop dependence or abuse it in any way. So I often end up maintaining, and that's why I say it's ironic that I'm doing this, because I haven't successfully detoxed many patients off their benzos, or their opioids for that matter. Now, I was hoping Myra would be here, so I found this slide. What I do get is a lot of pain patients sent to me for detoxification from their opioids. It's sort of a mixed bag. I put this here just because a lot of the patients actually, they are referred to me by a headache clinic at St. Luke's Roseville. Are you guys familiar with that? They will not prescribe opioids. It takes several months to get an appointment there. By the time their patients get there, they've been prescribed Percocets, Vicodins, and they're taking them, 10 to 12 a day, and still having headaches and not having adequate pain relief. And they get to the pain clinic, and I don't know where they found me, probably on the Continuum website, but I get referred patients for detoxification off the short-acting opioids. So this, I'm sure that 50% of patients with chronic pain do not attain sufficient relief, and they change physicians to seek more relief. Reasons include failure to take the pain seriously, insufficiently aggressive treatment, apparent lack of knowledge. So a lot of clinicians are not prescribing, such as St. Luke's, because of limited training, knowledge, and skills. Quite honestly, I think there's a fear there of prescribing opioids because they don't want people to come to the clinic to access opioids, so they just have a general rule. A lot of pain practices are the same. Some of these patients need higher doses. There's a fear of prescribing sufficient doses. There's stereotypes. There's all sorts of reasons why people don't get adequate treatment for opioids. And then the patients also are unwilling often to use the opioids, and they think they have addiction if they do take them around the clock. So this is often the patient I get that has inadequate pain, and I'm asked to detox them. So, or the other patients I get are actually from here, from the pain clinic here, who detox has been attempted. There's something very complicated. There's a fear of substance use. They're not stable. So somehow, if they can come and see me, I often get the referrals from the pain clinic here. So the patients, more that they're concerned that they're misusing their medications, they don't have a diagnosis of addiction or opioid dependence. So there's sort of two groups here. You know what, when I get them, it really doesn't matter to me which camp they fall in. The only thing that does matter is what diagnosis I put down on their insurance form, and also for getting buprenorphine, which I will not put, even if a patient is suspected of having opioid dependence, which is addiction to opioids. Usually you really can't make that diagnosis until you know a patient over time. So what I'll put, this is just a practical point for those of you who actually have to fill out insurance forms and get authorization for medication, is 292, just that they're in opioid withdrawal, and I'm treating them with opioids for detoxification. So rather than give a diagnosis of opioid dependence, which I'm not really even sure of, this is what I'll use. And pain patients often do not want that diagnosis. So the opioid dependence diagnosis is 304.0. So I'll just, okay. So then there's different types of withdrawal from opioids. There's the acute withdrawal, or even benzos actually, which is most intense during the first week. And then there's something called a protracted withdrawal symptoms. These are prolonged subjective and physiologic symptoms lasting weeks, months, or even years. Now the question is this craving and addiction? But Or is this happen in pain patients? Have you seen this in your pain patients without a diagnosis of dependence? Where they have craving, fatigue, they get sweats, even sometimes physical withdrawal symptoms after coming off their opioids? I've had a few patients like that, and they definitely don't meet addiction criteria. So protracted opioid withdrawal, this is after patients have been detoxed, include anxiety, depression, insomnia, fatigue, diarrhea, muscle and joint pains. And this abstinence phenomenon may develop despite a long, slow, judicious taper of the dosage and is hypothesized to result from chronic neuroadaptation. So it's very interesting. We know that addiction to opioids is a chronic relapsing disease of the brain, and we don't know whether this is genetic and people are born with it, or it's after continued opioid use it creates the neuroadaptation. So it's just interesting to use these different definitions, which aren't quite. They're very loose term, and there's a lack of consensus on the definition. Protracted withdrawal. Is this just craving and addiction, or is this a very real syndrome? I do think it's a very real syndrome because I've seen it in some patients who I definitely would not give a addiction diagnosis to. So while I'm here, I just thought I would cover opioid replacement and the legal. You really need to understand this, or you can get yourself in trouble in the United States. This is very specific for the United States. You can use any opioid for the treatment of pain, and therefore you can use any opioid for detoxification from pain meds in the outpatient setting. Okay, so you can use methadone, you can use buprenorphine, even though that would be an off-label use of buprenorphine. It hasn't been used. When you're detoxing, or even as you know for chronic pain, long-acting opioids are ideal. And really my experience is all with methadone and buprenorphine. For addiction, for patients who do have this diagnosis, that's why it's very important what you put. You can't put opioid dependence and then treat them with methadone. You can treat opioid withdrawal symptoms in a chronic pain patient to detox them with methadone if you feel that's the best drug. So don't give them a diagnosis of opioid dependence and then detox them using methadone. So, So for addiction and detoxification, for addiction to opioids, we have only methadone and buprenorphine available to use. Methadone can only be obtained from a licensed opioid treatment program or a methadone clinic, and buprenorphine can be obtained from the clinics, or it can only be prescribed for the treatment of addiction by a certified physician who has their X number, which just means you have to fill in a form and file it with the federal government. Does anyone here have their X numbers?
What does that entail? Literally just filling out one extra form?
Really?
No test or anything?
No. Well, no, you have to do an 8-hour training. I take that back. You have to do an 8-hour training, and you're limited in the number of patients you can treat in a month. It used to be 30, but they increased it to 100. So it's ironic. Usually you want to treat a lot of patients so you get good at it, but not with addiction. Addiction, we want to only keep a few on our practice and limit it. I don't know, but eventually they figured this is ridiculous, so they increased it to 100. Why they're limiting it at all, why they're putting barriers up to addiction treatment, such as filling out this form. I mean, the fact that you all are in pain medicine and no one has obtained their X number is tragic, really, if you think about it. Okay? So what's wrong with this picture? But you can use buprenorphine off-label for pain. So if you choose to, again, there's a reason I put that diagnosis there. You guys don't have your X number. Buprenorphine's a great drug. It's an analgesic. I'll talk about it a little later on. But you may choose to use it for detoxification or even for chronic pain off-label without your X number. The problem is it probably may not be covered by the insurance plan, and it costs a fortune. So So opioid detoxification is usually not life-threatening. I had a patient once. I worked at Phoenix House. It's a residential facility, and an older woman with HIV, end-stage AIDS really, just came in, and of course they don't use drugs, so she was going through terrible, terrible withdrawal, and she was so frail and fragile. I sent her for an inpatient just because it would have been, I was actually worried about her. You can have seizures and die, particularly if you're not well. So you can treat with tapering doses of a long-acting opioid. Again, we're talking methadone, buprenorphine. I would use OxyContin. Do you guys, if my patient was stable, do you guys use that? Or would you use short-acting opioids? What do you do? I'm just curious. I mean, I use 2 drugs, methadone and buprenorphine, but if I was in your practice and I was not comfortable and familiar with these drugs, which you probably are not, they're complicated somewhat. How do you taper the patients generally?
Typically they're long-actings anyways to start with, so just taper whatever they're on.
So you just use what they're on. Okay, so that is another way to do it, which you can do with pain patients. What if you all of a sudden decide they really have an addiction problem and you're uncomfortable prescribing these long-acting valuable opioids? What would you do then? Have you had that issue? Do you send them for inpatient detox? Send them to the methadone program?
We have an addiction psych fellow that
Okay.
works
Is it a nurse practitioner that does it?
No, it's a psych.
Oh, the fellow from Psychiatry.
Yeah.
And what do they use?
So, typically, we'll kind of do what I said, just taper whatever they're
Okay.
on. If they need something inpatient, or need something more, then try to get an inpatient.
You'd send
Which usually, in my experience, will refuse.
right to come in.
And then you're forced to just taper whatever they're on.
Okay, so you'll just use what they have. You won't switch them over. Okay. I guess what I get are the patients who have private insurance and can afford it, but also are frustrating. They're the pain physician is feeling very uncomfortable using whatever they've been on for a variety of reasons, probably misusing it. Most of the patients that I get sent have not had issues with diverting it. So I will use methadone or buprenorphine, but you can also, while you're doing this, is use clonidine. I use clonidine a lot when I get patients who have these are patients with substance use disorder, opioid dependence, addiction, and really the buprenorphine is what I feel is inadequate, but they will not go on a methadone program. Obviously, I cannot prescribe methadone or anything else in my office, and all I have is the buprenorphine. So when I induce them, and if they're still craving, still not sleeping, still obvious in withdrawal, to stabilize them, I will use clonidine to treat these withdrawal symptoms and try to get them through this period until their tolerance comes down. So usually take it at night a few times a day, and it seems to work. I'll also give them some clonazepam. I mean, anything to sort of treat the anxiety and the insomnia that comes with withdrawal. And then if someone's very motivated over time, their tolerance does come down and they can sleep. But usually they need a high dose of the buprenorphine, or they relapse, or they end up on a methadone program. But you can treat the withdrawal symptoms with NSAIDs, antidiarrheals, hypnotics, just really symptom management. So are you using methadone a lot now? I don't know if, when I did my fellowship 5 years ago, this place loved methadone, but I don't know, with all the QTC, you're still big on methadone here. Okay.
We do. I have quite a few patients who are in a methadone program getting 70 milligrams a day, but then they're getting, 200 milligrams a day for pain spread out over, 4 times a day. So that's not really answering your question, but I'm curious how that.
Yeah, I'm more than happy to talk about that.
Yeah, it's just surprising me
That's allowed. Well, first of all, the first thing I did when I found these patients, when I, all of a sudden flip, you're on the other side of it, would be to call the Methadone program. And because I was the medical director, I could get straight through to whoever I needed to, unlike probably any of you, which it's like guarded like Fort Knox, the security to speak. But the reality is Beth Israel Medical Center, if the patient's on our Methadone programs, we can talk to you. So just call them up, ask for the nurse, and we're one big program legally. So confidentiality for substance abuse treatment doesn't apply. If they're from another program, there needs to be a release at that end and a release at this end for you guys to talk about substance use issues. I would not prescribe to a patient without talking to the Methadone program, which took a long time. Even, when it was my own program, it took me like 15, 20 minutes to figure out what were the latest urine tox, is this patient stable? The program knows the patients. You do not. You see them once a month, if that, even though you're supposed to see them every week because, prescribe small amounts and see them frequently. That doesn't happen. If you see them once a month, that's probably good, right? So I would speak with the program. How often do you do that?
Do we do speak with methadone?
Yeah. I mean, you have to step back. All of a sudden, this patient is going to take you another 15
times, but yeah, it's hard to get through.
Right. So, I mean, there was a whole paper actually published. Dr. Cruciani, I think, wrote it with, there were a few of us, and I had a few patients from the Methadone program that I had chronic pain, and I decided their primary problem in life was their pain. And their addiction was asymptomatic, and therefore we could transfer them, even though they were on methadone, from methadone maintenance treatment to the pain clinic. Then it was a case study. Then there were 4 case studies, of course, from pain, who they decided these patients, although they had addictive disorders, could be maintained as an outpatient basis and not go to the pain clinic. Now, 5 years later, turns out all those patients did relapse and get into trouble. And the methadone patient that I transferred, who, I don't know, she ended up working in the clinic, so I did follow her, remained stable. So I think it's too hard for you guys to make that decision. I would feel very nervous treating someone has addiction without them being in addiction treatment for their opioid dependence, just to cover yourself. And I have a patient now in my private practice who he does have chronic pain, and I work with Dr. Cruciani, and together it sort of checks and balances, because when he has pain crisis, we'll prescribe him oxycodone, OxyContin, he gets through it, then we'll go back to the buprenorphine. But I could do that myself, because I am board certified in pain. I feel very nervous without working with a pain specialist, and I'm sure Dr. Cruciani wouldn't do it without working with an addiction specialist. So just for the comfort, and the two of you are sort of talking to each other.
What company do you guys use for your toxicologies? Because I've tried to look them up, so I don't have to call.
We don't use the hospital.
Okay.
The hospital,
we
won't. No, we send it to Ben Diner Schlesinger. We do about 12,000 urine toxicologies a month. It would burn out all the machines here. And there are labs that just do this. So the hospital really didn't want to do it. And they also charged way too much. So we have negotiated low rate because we have volume. So you don't have access to that. But we do them at least once a month, if not more. So you can go back 6 years, 6 months to, 6 years. You can go back 20 years. We have them forever. Okay, so methadone for addiction is only taken once a day. Remember, you're not treating pain. You have to give it in divided doses. For detox, again, you can do it once a day. Detoxification from pain medication, just to reiterate, not addiction is allowed in the office if properly documented. Methadone, so you can use methadone. It has a long half-life. It's safe and effective. And then there's the QTC issues. We do not screen in the methadone program when we start treatment or even when we go to high doses. Mainly because we don't have the resources to do it, but quite honestly, we don't have a choice of medications we can use. These patients, if they're on a high dose, that pretty much means buprenorphine's not going to work because buprenorphine has a ceiling effect. So our thinking is that the risk of continued heroin use and overdose and active substance use is more dangerous than torsades and prolonged QTC. But this has to be explained to the patient, documented, and we do offer them a cardiology consult. Do you guys do EKGs prior to starting? What sort of doses are you using?
High doses.
Extremely high dose. Most of them have been inherited from previous treatment plans. It varies.
I have a patient who takes 48 pills a day.
Okay, 480 milligrams. Just so you know, most of our patients, our average dose in the methadone program, and I'm actually proud I've got it up, is like 90. So in the research, the original research done by Dole and Niswander from Rockefeller, by the way, where the Beth Israel methadone programs came from, were the oldest and the first ones, the average dose to stabilize a patient who's injecting heroin, pain medication's a whole other story, is like 80 and 120. We have maybe a handful in our 8,000 patients we see above 200. So when I look at those patients, there's usually someone who, HIV patients on medications or on some medication which is causing increased metabolism of the methadone, or often psychotic patients. When they get psychotic, they'll somehow get around the system and keep increasing their dose. They know how to, we're very patient-oriented, and so if a patient says they need more, we want to give them more and quickly, but somehow they figure out how to do it without ever seeing a physician. So if they are going to psychosis, they'll very rapidly often ramp up the methadone. But really, we're not seeing the high doses you guys use in pain medicine. So for addiction, it really is just around 100. So that's sort of one of the ways I use. If someone's really taking that amount and not selling it, that's a pain patient. Because for addiction, you don't need those doses. What is your sense with the patients?
She has a consistent urine drug test.
When you say you only need to take one pill to get
you
it.
You need to take
right.
48 pills to be.
Right.
So she's also using hydromorphone 8 milligrams Q4. So.
What are you treating her for?
It's a hip pain.
So it's.
She's on benzo.
Is she walking and talking?
Yeah.
Okay.
Yeah. My highest is 200 something a day.
This is the patient who's on like 70 with 40 4 times a day? Or 5?
Something like that. He's on a lower dose of the program, and then we had him on 200 something a day. And there were some concerns at one point, and I had him come in for a pill count. It was fine. Had him come in and take an observed dose, and he did fine.
Yeah, no, I mean, what I tell my physicians, especially in the methadone program, we're not the police. Our job is to advocate for the patient. So obviously, responsible prescribing and best practices, especially in pain medicine, and considering your role models for all, yes, but unless there's something concrete, you have to believe the patient. And methadone is very effective pain medication. Most likely because you're giving 40 milligrams 4 or 5 times a day in addition, that once a day dose with the program's lower than it would be normally. So there's some, maintenance. And patients prefer, when they have their doses, they actually will divide it up on their own, because they say it lasts 24 to 36 hours, but it's much better to have smooth dosing and give methadone in divided doses. I'll show a little bit of the, oops. Okay. I felt something. just if these are just practical. Oops. Okay. Okay. In the hospital, all those rules about addiction, pain, whatever, they're out the window. You can use any opioid on any type of patient for addiction or pain management, either for maintenance or detox, when the patient is in the hospital. And this is important because a lot of patients come in with prolonged QTC, beautiful documented torsades in the emergency room. So of course they get sent up to the floor and they stop the methadone. But you know, you can't do that. I mean, you can stop the methadone, that's fine, but you really still need to maintain them or they'll be out the door in 2 seconds. So, you know, often they'll be on a high dose of methadone. Not always. It could be someone in end-stage liver failure on 40 milligrams, so all of a sudden, you know, they're not able to metabolize the methadone. But you have to wait for the methadone. If you want to transfer them to, say, buprenorphine, you have to wait for the methadone to get out of the system. So what we generally do is use morphine, short-acting morphine around the clock to keep them comfortable with some clonazepam until their QTC normalizes, or you know, they've been here long enough, we can switch them and do a buprenorphine induction in the hospital, which is always a nightmare because you can't get enough of the drug on the floor to quickly ramp it up. And if someone goes into withdrawal or it's too slow, it can turn into, it's very hard to do an induction in hospital, I've learned. Or if you do intend to do it, order a lot of extra medication so you have it there by the bedside. You can't just order it, oh, get another dose. 3 hours later, it'll come up from the pharmacy. So we don't use oxycodone because in theory it prolongs QTC in the test tube. I guess any of them, they say in theory. The cardiologists say that buprenorphine does not prolong QTC. So going back to inpatient opioid detoxification, the DRG only will pay for 5 days. So the inpatient detox does not accept patients on greater than 40 milligrams of methadone. So if you want to send a patient, you know, for detox inpatient, they won't take them unless it's 40 milligrams. If you have an active drug user, either they're using heroin or pain medications, and they do a detox in hospital, they just give them 40 milligrams, 35, 30, 25, you know, 5 days they're done and the person's climbing the walls and out the window and they're ready to use again. Really what I would like to recommend is maintenance treatment in hospital, but I think some of the residents are doing this because it makes so much sense, but that's generally not the policy here. When we do a detox in the methadone program, and I would also recommend it in pain practice, we do not decrease the dose by more than 10% in the week. Now, if someone requests a voluntary detox, we'll go a lot slower. I mean, they need to know the point of the taper is to maintain abstinence from illicit drugs. So if they're craving and relapsing, they really need to go back up on their medication. So you can go slower and, again, stop and raise it. So just do not destabilize the patient who's usually motivated because their life is stabilized, but they don't really understand they need the opioid. You know, I'm talking addiction. I'm going back and forth between pain and addiction. Actually, I think a lot of the pain patients need the opioid, whether it's for pain or not, to stabilize their life. So buprenorphine, are you guys using it at all? Oh, it's, or okay. Well, anyone using buprenorphine? A little bit. This is a partial mu opioid agonist. It has a ceiling effect. So basically, as you can increase the dose, but at a certain point, usually around 32 milligrams, you will not get any more opioid agonist activity. You will, however, get all the side effects that go with it. So we don't go above that. I don't believe this low level of physical dependence unless withdrawal discomfort. That's what they're promoting. But there is a very real risk of precipitated withdrawal when you do use it. So the reason for this is if you have a full opioid agonist, such as methadone, oxycodone, and you're trying to transfer someone to this long-acting you know, this is the scenario I get. You know, someone's on either short-acting oxycodone or methadone or using heroin, and, you know, I don't want to prescribe those medications because I'm concerned they may misuse them, or I want to get them onto maintenance treatment for addiction. If they've taken a full opioid agonist, which is activating the receptor, and you give them buprenorphine, the buprenorphine will actually dislodge the agonist from the receptor because it's stickier, but it will like down-regulate it. So it'll slam on the brakes and you have precipitated withdrawal. Your patient will hate you forever. And with pain patients, there's a very real risk of precipitating a pain crisis, which they may not recover from. So I get really nervous when I get the pain patients. The last thing I want to do is, because I have done the precipitated withdrawal a few times, so I take a lot of time to explain to my patients that they should really tell me the truth about when the last time they used and what they used, because they'll say, no, of course I haven't used anything. No, if you have used, you know, if you've used something, you should really tell me, because you can't take this medication. They just don't realize how quickly they can go, like right before my eyes. I've seen someone very quickly go into withdrawal. So usually you say 6 to 12 hours, I guess, with oxycodone. I have had patients recently who were misusing oxycodone, and they waited less than 12 hours, and they had a little precipitated withdrawal. So to be safe, I would definitely wait more than 12 hours with the short-acting opioids to prevent precipitated withdrawal. What's the treatment of precipitated withdrawal? More buprenorphine. Or if it's the patient who's really unhappy, they'll go out and use heroin again, because you can always get on top of it if you take enough of anything. So you really don't want to do that and lose the patient when you finally have them engaged somewhat. So it comes in 2 milligrams and 8 milligrams, with or without naloxone. Generally, they recommend for pain treatment or induction or even detoxification that you use the buprenorphine or Subutex. Reckitt Benckiser has actually stopped making Subutex. They only make Suboxone. Suboxone's in combination with the naloxone. Does anyone know why they do this? to make money, yes. That's okay. Well, that's one of the reasons. The theory being that if the naloxone's only active if you chop it up and inject it. So they feel that if they combine the buprenorphine with the naloxone, patients will be less likely to inject it. And it's not absorbed sublingually. The reason you use Subutex in pain management, because of the fear of 2 or 3% may be absorbed under the tongue. The reality is, I just gave you a long lecture about precipitated withdrawal. So if you have opioid dependence and you are opioid dependent and you inject pure buprenorphine, you're going to put yourself into withdrawal. So for someone who is actively using, the naloxone may attenuate the high, because it'll get to the receptor first, but again, buprenorphine is sticky. It will dislodge the naloxone. It will dislodge just about anything. In addition, there was a very good paper in Malaysia. Somehow, if you get just the right dose, you can actually maintain yourself with IV Suboxone. But of course, you have to use frequent low-dose injections. So that actually increases the risk of HIV/AIDS in these countries where it's being misused. So I'm not a huge fan of the Suboxone combined preparation. If you don't have opioid dependence, then you won't even feel the naloxone, because you're not at risk of precipitated withdrawal. It may, again, attenuate the high initially. So I get confused about this combined prep. It certainly has not prevented intravenous use of Suboxone. Again, FDA has not approved the medication for the treatment of pain. It's a very good pain medication, needs to be given in divided doses. It's used all over the world. I actually trained in England, and it was called Temgesic. So it's for moderate to severe pain. the problem is you won't get it authorized unless you have an X number. So you guys should all get your X numbers. And then if you're nervous about a patient and you want to treat them with Suboxone or detox them with Suboxone, you know, they can get coverage. Medicaid may not actually be, are most of your patients Medicaid? Okay, so Medicaid, you don't have the insurance nightmare that every prescription I write needs to be authorized with commercial insurance. It costs at 24 to 32 milligrams about $1,000 a month to treat these patients.
The majority of our Medicaids just all went to managed Medicaid, so pretty much everything does require
But buprenorphine, actually, for buprenorphine, it wasn't so much authorization. They wanted 2 urine toxicologies. Hi, Marilyn. So, but anyway, you guys should get your X numbers. I mean, you know, just if you feel uncomfortable using pure agonists with a patient, then I would use buprenorphine and cover yourself. Okay. It's safer. There's less risk of overdose because of the ceiling effect. There's less respiratory depression. It is being diverted. Of course, as a physician, unlicensed professional, you know, the use of prescribed medications as not intended is a terrible thing. From a harm reduction perspective, diverted methadone is probably going to those who cannot afford treatment or access treatment or use it, that patients are using it to prevent withdrawal, except of course the population that is misusing it are young teenagers, primarily on Long Island it appears, who don't have any tolerance. So they are misusing the buprenorphine, and there have been some deaths. So it's, you know, it's a balance between, you know, is it helping, is diverted methadone helping people more than it's hurting them? We don't hear about the people who are not dying from overdose deaths because of diverted buprenorphine or not getting HIV because they're not having high-risk activity because they can't get their drugs. This drug lasts up to 72 hours. So for, you can actually, I don't do this, just in theory, only give it once every 72 hours. Most of my patients, you know, take it 3 times a day, so I don't know. Again, it's expensive. I don't see any advantage of it over methadone other than it can be prescribed in an office and is somewhat safer. So clonidine, cataprest, do you guys use this for pain as well? Are you using this or just for the, what, the intrathecal? Right. There's a whole, what is it, Cochrane database, I don't know, anyway, lofexidine, which I don't know where I'm supposed to get, is better than clonidine, but of course methadone and using an opioid to taper off opioids is better than all of them, but this does work. So, principles: individualized patient care. I guess this is for pain medicine and for substance use. This may be. Okay, so this is, so if you're pain patients, okay, you haven't given them, now I'm trying to remember why I stuck this slide in here. So you have your patient, and I have a lot of these that get referred to me. I was gonna, okay, so here, right. So I have my headache patient clinics coming into my various patients, and this is what they're doing. They're taking a handful, you know, every 4 to 6 hours, they're taking a couple Percocets, oxycodone, they're going up and down. They're getting pain relief, and then they're going into withdrawal. They can't sleep at night. They're a mess by the time I get them because they're taking short-acting opioids, which are not lasting both pain relief, and they're going into withdrawal. So so I use buprenorphine to detox them, and what happens as soon as I give them the buprenorphine is they get this nice long-acting effect, and their headaches go away, and they want to be on this drug. They don't want to come off. In fact, I've often said, I'll call your doctor, and they can, you know, just take OxyContin, you'll be fine. They're like, no. They have relief. So for many of these headache patients that I'm detoxing, I end up prescribing buprenorphine long-term for their pain with clonazepam, and the headache clinic will, you know, do Botox injections, but because they're on the buprenorphine, all of a sudden they don't need the propranolol, they don't need the NSAIDs. What else? They don't need the Topamax. What else do you use for migraine treatment? There's a handful of drugs that if you give someone a long-acting opioid, all of a sudden they don't need. So usually they just go for Botox injections to the headache clinic. So buprenorphine works. And I stop the detox, and that's okay with the headache clinic. As long as they don't prescribe the opioid, they're fine with that.
How much do you use and when do you start it?
Well, you know, we go into this thinking I'm detoxing you off the short-acting opioids. I know in the back of my mind the reason you're having problems is because of that up-down effect, and all you need is a long-acting opioid at a higher dose. So I'll wait 6 to 12 hours, right, because you don't want to have precipitated withdrawal. And then I usually start on a low dose, maybe 2 milligrams, 3 times a day. If they have been taking, so what's happening here is they're taking short-acting opioids, but also in inadequate doses. So usually, in the end, probably 4 milligrams 3 times a day will work for someone. But I let them find it. And then, you know, migraines, a lot of it is stress-related. So if they're comfortable and happy, over time, they'll be able to decrease the dose. But generally, they still need it, maybe down to 2 milligrams. Also give them a little clonazepam, which no one ever prescribed to help them sleep. Their pain and migraines. I'm talking about really high-powered lawyers. All they want to do is work, you know, that they're suffering from this. So buprenorphine works great. And of course, the diagnostic code I put on their insurance is that 292. What I'm really doing is not treating their pain, but treating their withdrawal. But it's very effective for their pain. So this is basically what I'm saying. But also for detoxification, it's just a slower, more consistent detox. A few minutes. This was funny. I found this slide. Okay. Does anyone know the answer to this? Basically, any volunteers? So basically, these patients that I get referred for detox are limited by the amount of opioids, and that's the real reason that no one successfully treated their pain and not using a long-acting. I have to say, I just put this in at the end. Looks like we're running out of time. It's not easy detoxing patients, particularly the pain patients. They call me more than my substance use patients I'm detoxing. Their anxiety levels seem to be higher, and it's actually one of, you know, the substance use patients are very clear on how to use drugs to make themselves feel better. The pain patients often don't know. So I struggle with this every day, and particularly now that I have a handful of the pain patients who are like, you know, I feel nauseous, my headache is like, I get a lot of phone calls. So I need to rely on these skills more myself and set clear boundaries with them. So I'm sure, I don't know how many phone calls you guys have to take, but do you? Do they get through? Your patients from clinic? Yeah. Okay. So, yeah, it's hard. It's definitely harder to treat the pain patients and detoxify the pain patients than substance users. I don't know what it is, but it's one of my ways of distinguishing who's the pain. If you're ever confused, this is what I was taught here. Just document the 4 A's, and I do this, I use this also for addiction, except I put, you know, addiction stable, so I'll address their addictive behaviors. But if you can document clearly why you're doing what you're doing, how you're doing it, I think that will make you feel more comfortable when sometimes you're a little unsure what's going on. So I don't think we really have time for these case studies, but any questions? I'll take